Hi, everybody. Welcome to the February installment of the Academic Life and Emergency Medicine Book Club. For this month, we have Emperor of All Maladies by Siddhartha Mukherjee. And we have a nice international panel this time around from two representatives from Canada here with us today. So first, I'm going to turn it over to Aaliyah. This was your and Paul's idea to suggest the book, and before we get into the questions, I'm curious as to why you decided to choose this book.
So Paul and I were both actually tweeting about this book before we brought it to ALiEM Book Club, and I think we both felt like it was one of those books that combine not just medicine and technology and the technical aspect of science, but also the really humane aspect of what we do as doctors, and especially in oncology. And I just found that as I was reading the book and getting intertwined in his stories and in his retelling of stories, it was just probably one of the most natural ways to learn about cancer and about the advances in cancer, while remembering how it changes us. I love the book, and I've read it so many times since I read it the first time as a clerk.
All right, I agree. I think this book was definitely full of stories. All right, so let's get to the questions, Aliyah, which you wrote, which were excellent. So the first question, which is in page 338, in part 5, Mukherjee describes how medicine has changed his colleagues. Quote, "Our encounter with cancer had rounded us off. It had smoothed and polished us like river rocks." And the question is, patient interactions change the way we not only see medicine, but also see each other and ourselves. Does medical curriculum provide sufficient time and space to allow learners to reflect on their personal changes as they begin to interact with patients? How can we help capture and foster the reflection necessary for learners to understand these changes in themselves? So I'll send this off with you, Aaliyah, first. What do you think?
So I think one of the parts of the book that I appreciated most was when Mukherjee was actually talking about his own experiences, because he really captured it in a voice that was so reflective and so introspective. And I remember thinking and wondering if I thought about medicine in that way. And I think that we all try to encourage reflection. We debrief after traumas, and we have reflective writing exercises in medical school. But I'm not sure if that's enough to equip residents and medical students when they go into clinical practice with what they see and what they experience. And I think I'm not sure what the answer is in terms of how to do it, but I think it's something we need to consider, because I noticed that once I got to the wards and my colleagues and I got to the wards, there was less emphasis on that introspection and that reflection. And there was a lot more emphasis in getting the work done and being a doctor and being a resident. And I think that's really important in checking in with yourself and looking at, how have I changed, or how do I see this one case or one trauma differently than I might have seen trauma 6 months ago when I started residency, or 2 years ago when I did my first EM rotation. And I'm not sure what the answer is, but I think it's something that we need to keep asking, and asking juniors and asking staff, and seeing what we can actually do to help foster that introspection so that medicine becomes less of a technical skill and more of an art, as we are all trying to make it.
I agree. Paul, what do you think?
So I've spent a lot of time thinking about kind of our role in medicine, and how much time we do spend reflecting on those tough things, whether it's the death of a patient, whether it's a traumatic encounter that you've had with staff, whether it's a teaching encounter that didn't go as well as you'd like. And I think what Aaliyah said is really true, that sometimes there's kind of the formalized component of the curriculum where we're asked, or in fact compelled to write some sort of reflective piece on an experience that we've had, and I'm not sure that that's necessarily the best way to encourage reflection. But I think really the informal debriefs, whether it's over coffee or maybe at the corner pub having a beer with some friends, are the times where we really have the opportunity to kind of take a step back and kind of find out how medicine has changed us. And so certainly I think the biggest thing for me that I've learned through my experience, in my training, is that I need to stay in touch with my family and my friends, because they often are a great mirror for us to let us know how much we've really changed. Because I do think that in our encounters with patients and what we've learned in medicine, it does have a profound impact on us, and it really does change us. And so by talking with people who've known us kind of before, during, and after, that can also help kind of keep us grounded and add perspective when we're doing that reflection.
I agree. I completely agree.
Yeah. You want to expand on that, Matt?
Well, I think the most important thing is realizing that what you do changes you. And the biggest danger is seeing patients and thinking that it doesn't have an impact on you or it doesn't affect you. And what you're mentioning is realistically, it's those spontaneous, informal debriefs that happen over a cup of coffee or a beer, that tend to be the most insightful. And it's important because it keeps us human and it keeps us attached. Whenever you're telling a medical story to someone who's outside of medicine and you find yourself saying, well, this is normal in the hospital, and you realize how far it's affected you, it's important. But I also think it's protective. I think in a busy shift, being too affected means that you can't treat the next patient. And we build up these defense mechanisms and these distances for a reason. And I think that they can be helpful and protective. But I've definitely worked with colleagues where I've had a difficult trauma resuscitation, or actually new cancer diagnosis can be very difficult also, especially if they're young or close in age to you, or they have children close to your age. And just realizing that it's affecting you and taking a moment, and maybe that means I've known someone who's gone into the bathroom for a little bit, or maybe that means taking some time. Or if you can, putting it into a little box, sadly, keeping it till the end of shift, and then with your family or friends or others, just debriefing and thinking about it. The biggest thing is just continuing to do it. And while I think it's an important part of medical education, the real question is how you integrate it as a physician throughout your life and throughout your time.
I think that integration is the real hard part for a lot of us as well. And one of the things that I really appreciated from a mentor that I had during my residency training was his kind of reflection on my use of language. And so he did a really good job of just sometimes reminding me that we have our own language within medicine, and that's a very different language than many of our patients understand. And so I think, being mindful of the words that we use and the way that we interact with people is also really important. And the times, as you say, when you're recounting a story or telling someone something, that I kind of am forced to pause and reflect is sometimes when you get that immediate reaction from someone and you find yourself, again, saying, this is normal for us, but it is so abnormal to kind of those of us who aren't working in the medical field or who don't encounter these sorts of traumas, whether it's a diagnosis of cancer or death of a loved one or those sorts of things on a daily basis, and yet we often do. So what has become our normal is very abnormal for most.
But I also should say I think that that's in a way a gift, and I certainly have grown as a person, and I feel comfortable with some of the darker aspects of life and death because of my professional experiences. And I know a lot of people that are my age with my experiences but are working in retail or something else, and they don't have the pressures that I do, but they also haven't necessarily had the opportunity to grow and really connect with their sort of human brethren in a way as much. And that's really a gift and an honor. In terms of language, it's interesting. I knew somebody who always used to hate the phrase pleasantly demented, which you hear fairly too frequently. Because they said, it's pleasant for you, it's not pleasant for them and family. And I agree. And so, yeah, just thinking about the words that you use in the language and how it reflects on your thought processes and your emotions.
Yeah, and I think one of the points you just said, Paul, was that you do writing exercises in the medical curriculum. But I think that unfortunately makes the process of reflection in medicine seem kind of like a homework assignment, or for those who may not be so intuitive, it just may come across as a silly emotional activity when there are other things to learn like pathology and anatomy. And I think maybe taking that emphasis instead on writing reflection and more on debriefing / meeting at a bar in a healthy, safe manner and talking it out may actually be a better way of dealing with it. And so earlier in the medical curriculum, I think there's too much of an emphasis on the actual writing process, and maybe if they could incorporate some of that real-time debriefing earlier, that could be helpful.
And I think one thing to add to that, because I totally agree, and that was one thing that I really thought about in medical school in terms of reflective writing, and why are we being forced to reflect, but it isn't the most natural way of debriefing. We all have our own ways, if it's coffee, if it's running, if it's art. And I think that one of the solutions I've reflected on is maybe the answer is not making everybody reflect. Maybe it's allowing space and making it okay for people to engage in their own introspection. So encouraging medical students to continue with painting or dancing or running or whatever it is, and actually creating a really safe space and acknowledging that as a form of reflection. And that makes it okay and really intuitive for someone. And it's like, oh, medical school thinks it's okay to paint, and that's a form of reflection. And I really enjoy that. So maybe as a resident, I'm going to continue doing that.
And I also think, though, that there is a power to writing that's a little bit different. I was creative writing undergrad and worked with Jay Brook and some other people at Rhode Island who do a lot of great medical humanities work. And this book is essentially a product of that, right? I mean, there's a lot of nonfiction in it, but the author is obviously going through his own catharsis in terms of processing what's affected him. And I remember I was resuscitating someone that was very old and had a very poor quality of life and just felt terrible at the end of it, and actually did kind of write a quick poem as a way of trying to process. Yeah, so whatever art or other sort of outlet you have, catharsis.
I've actually had a really unique experience just recently with someone else's creative writing that was actually inspired by an experience or a series of experiences that I've had and tweeted about. So I know a poet by the name of Jonathan Bennett, and he actually asked if he could use one of my reflective portfolio pieces that I wrote as part of the medical curriculum as the basis for a poem that he wrote. And it was interesting because it wasn't my own words and it wasn't my own voice, and yet it was so much of my own experience captured so beautifully. And so that was kind of really neat because he put a different spin on it, but you could put yourself into that place and you could remember some of those encounters. And so that was something that I thought was kind of a unique privilege when he said, could I use your words? And I was thinking, I want to use yours.
I wondered, do we think that for whatever reason is listed in the front for why this book was written, was this really a reflection piece for Dr. Mukherjee? I mean, is this how he maybe kept his sanity and his humanity during his fellowship? I wonder.
I think it's a fair question to wonder.
Yeah. All right, let's move on to the next question, which is, in page 400, there's a quote. It is an old complaint about the practice of medicine that inures you to the idea of death. But when medicine inures you to the idea of life, to survival, then it has failed utterly. And the question is it possible to prevent yourself from becoming inured to the idea of death? What advice would you give learners and juniors to not become inured to the idea of life and death? Paul, let's start with you. What do you think about that question?
I think it's a really good question. It's something that certainly in the emergency department or even critical care environments we struggle with kind of on a daily basis because we're so frequently faced with things that are just so horrific, whether it's trauma or death or severe illness or conflict or any number of things that could make us, jaded or cynical or kind of otherwise desensitized, because there is, as Matt was saying, a need to kind of compartmentalize things so that we can actually continue with the job at hand, which is caring for our patients, and making sure that our team is cohesive and moving forward. And so sometimes I think we have a tendency to use humor, at least I know I do, as a coping strategy. And so that can be that gallows kind of humor that people use, jokes that in really any context would be deemed to be inappropriate, but in that context seem somehow an appropriate kind of way to vent some of our own frustrations. And so it's really hard to find that balance so that we don't become kind of desensitized to life or to death. And so I think what I've learned from kind of experience of my own, but also from the experience of my mom, who's an emerge nurse for many years, is that we really need to stay connected with friends and family outside of medicine, because they're the ones that kind of keep us grounded and keep us in touch with reality. And they remind us of kind of, what life is really about. But then also by seeing the really sick patients or those who, may die prematurely, that also reminds us how it's life is a gift. And so I think there is a privilege of being a physician and to be able to be there when people are suffering and be there at the time of a patient's death and to share that with them and their loved ones. And so I think it's those experiences and that contrast between what we do at work and what we see at home that really help prevent us from becoming too cynical or too jaded or too desensitized.
Aaliyah, what do you think?
I think one of the things that Paul talked about was really the idea of remembering the context, and that's something that I think I'm starting to learn as a junior, and my perspective is definitely of someone who's really new to medicine. And I remember, especially on OB-GYN, actually, feeling like it was impossible to have a normal pregnancy. Like, I felt like every pregnancy that I saw, there was a hemorrhage, there was a code, there was like a stat C-section that needed to be done. Yesterday in Emerge, I had like 7 like first trimester bleeds, and I remember thinking, like, is it even possible that anyone has a normal pregnancy these days? And I had to take a step back and remember, like, what we see in Emerge is a sampling of the greater population. And it happens when you're in any environment. It happens if you're in one hospital versus another. You might see a lot of cancer patients, or you might see a lot of trauma, or you might see a lot of pediatrics. And I think one of the things as a junior that I'm trying to remember is that there is a lot of healthy and normal in the world. You know, there are 6 billion people, and for the most part, there's a lot of healthy and normal, and that I think is what I took away from this idea of not being inured to the idea of life, and remembering that there is a lot of goodness, there's a lot of normal, and a lot of healthy to focus on and to remember. And our job is to find the zebras, and our job is to find, you know, the critical diagnoses and to make sure we don't miss those things, but to also remember that it could just be a cold, and that's okay. That's the perspective that I'm trying to remember and learn.
And I
Could I add one more thing? Sorry about that, Matt. I was just going to say the other thing is having fun in your workplace, I think, is really important as well. And I would say that's the one thing that I've really enjoyed about the place that I now work, is that we've got a great group of people who I really do think genuinely have fun every day at work. And so that really helps kind of find that balance and to prevent you from becoming too cynical or jaded.
That's a good one. That's a good one.
I think that it gets better too. I think also everyone being sick and everything being terrible is also a product of training. And, you know, it's the older docs who are like the calmest docs who are sure that everything's fine, just because over time you start to see a lot more normal and you start to realize that, you know, when you hear hoofbeats, it's horses, not zebras. And I think a great example of that is emergency docs and their kids. Like, they're like, he fell, he's fine, his arm is fine, his arm is twisted like this. The next day he comes in, it's like, oh, there is a small fracture, whoops. Or, you know, yeah, they got a fever, they're vomiting, they're fine. And so on some level I feel like, and docs are known for being terrible patients, but on some level you start to get a little more used to that. And I remember when I was working on the cancer service when I was training, and I would see these people, and they were 2 years into their chemotherapy, and they had PEs and all of these complications, and I would read some of the social work notes that were 2 years old, or 6 months old, or a week old when they were out in the community, and they're a plumber, and they're doing things. And I mean, especially with patients, I think it becomes really important to try to see them as human beings, and whether that means talking to their family about non-medical things, which as a fringe benefit in the ED also develops a relationship right before you want to do a procedure or, you know, consent them for something. But just seeing them as human beings really helps. And I think we get used to that. And I don't know that being inured to death is such a bad thing on some level, because I also feel like, and this gets into, I think, the next question, which is an excellent one, but when we talk about death or dying, everyone shuts down. I mean, especially in the U.S., we have a real problem with even saying the word sometimes, and that affects discussion of end-of-life care and affects a lot of things. But when you deal with someone who works in a healthcare setting, they are aware that the end of every story is the same. And so being a little bit inured to it, I think, can be a helpful thing because it allows you to see it for what it is. But definitely what you were talking about, Paul, with being joyful and being happy and being appreciative are important.
Yeah.
And I think recognizing that in your patients too. Like, I think when you both said that, I was like, I haven't thought of that before. And that's important too, to see when you do see patients who may have terminal illnesses or who may be really sick, but they still are joking or laughing or spending time with their kids. And I think that is a really important consideration, that they are still living and they do still. A lot of patients are quite resilient, and I think more resilient than we often give them credit for.
And I think that's also why this book is so thick. I make a joke, but this book is so thick because of the stories of the people in here. You know, Carla Reed is woven throughout this book, from her initial diagnosis, her treatments, her trials, what her family goes through, but also the stories of the doctors and the scientists who are trying so hard to find a cure. And maybe that's how the author was able to keep his grip on not getting inured, by learning the backstory of everybody, taking the time. He didn't just go into fellowship to become a cancer specialist. He came out of it and created something that was so much more in depth than what the typical doctor does. And just like all the points that you make, being an emergency medicine doctor, time is really critical for sick patients, but even for not sick patients, because you have to move, be efficient, be quick. And one of the things that I do try to do, and I'm not the best at it, but I do try to spend at least one moment when I'm getting a history and physical, usually during the social history. And I look at them and I pause and I ask them, what do you do for a living? What are you reading? What movie did you see? Or something like that. Look them in the eye. If they're sick and feeling pain, I try to just squeeze their hand for a moment and just let them know that for that moment I actually am paying attention. I am not distracted thinking about 10 other things that I have to do. I'm not impatient wanting to run out of the room, but for that moment I've actually just concentrated on them. And I don't know how it makes them feel. It makes me feel better knowing that I at least have stopped for a moment.
Yeah, I think if you can find that kind of little human kind of thread, to connect with them about, it's really kind of helpful. I know in my own center we have some patients that are followed for cancer diagnoses and for their chemotherapy, and one of the physicians who treats them often will dictate directly into her notes some of these kind of more human elements of the history. And I find that sometimes can be really helpful because you can kind of break the ice, and it's privileged information in a lot of ways, but it really makes the patients and their families often open up with you as well, because it kind of clearly lays bare some of their hopes and their expectations and their dreams and their motivations. And so saying that you recognize that that's, in some ways some of their motivation can be helpful in terms of kind of leveling the field a little bit.
And it's the secret weapon against burnout. I mean, if you meet a bunch of, like I used to wait tables, and I do the same thing. It's just like waiting tables. You meet somebody, you smile, you try to develop a relationship with them. And if I saw, somebody who was in World War II today, and I saw somebody else who met the president, and I saw somebody else who's, bakes all these cupcakes, it's a memorable day versus I saw a belly pain, I saw a chest pain. And also open talking to consultants and things about trying to get things done. If it's, she's this 84-year-old woman, she is so sweet, and she has these 6 kids, and she's from here, you really need to admit her, because she's got this, it's almost like they say when somebody takes a hostage, you should say their name to humanize them. I feel like just remembering that these are human beings really helps in the provision of care.
And I think
I love the waiting table analogy. I used to wait tables as well. It's so true.
And when the kitchen burns the food, it's not my fault, but I still have to deal with it.
I always blame the lab.
Your front of house.
All right, let's move on to the third question. And it's in page 401. Mukherjee describes how cancer mortality changed in the early 21st century and the scientific advances that led to a decline in cancer mortality. Mukherjee also describes how the New York Times refused to print the word cancer in the papers in the 1950s. Over the past few years, there has been an increase in the presence of cancer in media, with blogs, online support groups, Twitter chats, and patient-focused websites becoming a part of a patient cancer's experience. So the question is, how has the incrementally increasing presence of cancer in the media changed the discussion of cancer between a doctor and patient? In what way does it help or hinder the doctor-patient relationship? So Matt, I'll let you take first stab at this.
Yeah, it's a great question. Because when you're reading that book and you hear that the woman wanted to have a cancer support group, and they told her that it would have to be a discussion of women's chest wall issues or something to that effect, it's just shocking that the word cancer and breast at that time was not something you said. And I think the big thing that gets at is stigma. And with cancer, it's not just better treatments, it's also better awareness and better discussion of it. And especially when the book does a good job of talking about the viral theory of cancer, and when you don't know what it is, and you don't know if you can catch it, and you don't know, and it's just an aura of illness, you want to avoid that. And I think that the stigma around cancer has dramatically dropped. That being said, I think that there are 2 words you can say in a conversation that can make somebody's brain turn off. And at death, if you're telling somebody about their father and you say the word death, they don't hear anything else. And cancer. Once you say the word cancer, they don't hear anything else you've said for maybe a half a minute or longer. And I don't think that's changed. I still think that to most people, cancer is how their great aunt died. It's a death sentence to a lot of people, and some of that is that the statistics have not dramatically changed for cancer as a whole. I do think that medical literacy has gone up dramatically and stigma has decreased. So you can have that conversation, and I think that's great, and patients want to know more information. But I still think that cancer is, the emperor of all maladies. It is this great, mysterious harbinger of doom. And I don't know that we've gotten past that.
Paul, what do you think?
So I would really agree with a lot of what Matthew just said there. I think the challenge that we face as physicians is that even though the stigma in many ways has been rolled back and people are now much more aware of cancer and much more willing to talk about it, that awareness doesn't always translate to kind of true knowledge. And while there is increased medical literacy, I think sometimes we as physicians face challenges in that there's almost kind of like the pop culture awareness of a disease. And so I think the prototypical ones in this category would be probably breast cancer and prostate cancer, as they're kind of really, women's and men's cancers, and they have kind of whole networks of fundraising events and awareness campaigns and all these things. But I think for me, I've trained as a family physician first and then done additional training in emergency medicine. One of the challenges that we face as physicians is trying to reconcile the need to diagnose these things and to intervene on them, but also explain that there is potential risk for overdiagnosis as well and over-investigation, and that sometimes the harm that we do isn't necessarily in finding the cancer, but it's actually just the process of going looking for it that could be harmful in and of itself. And so that, I think, runs kind of counter to the pop culture messages that a lot of patients are now hearing. And so to have those more nuanced conversations is quite challenging. It's not to say that we shouldn't have them, but I think that's one of the challenges. I think the other one that I think about is awareness around other types of cancer. So if you think about cervical cancer in particular, that's a real challenge, especially here in Canada, about the uptake of the HPV vaccine. And so there's been kind of some renewed controversy as of late because of some poor investigative journalism, here in Canada recently. I think it's great to see that these conversations are happening, but I think unfortunately sometimes people equate their awareness to a kind of a more in-depth knowledge, and that then closes them off to a willingness to actually hear about the true evidence. So that's always a challenge to engage with our patients in those conversations.
Aaliyah, what do you think?
So I agree with what both of these gentlemen have said, and I think one of the things about when I read the book and was listening to the stories of cancer and cancer discovery, you get the impression that it was a really solitary journey for a lot of these researchers, especially when you go back centuries, that it was them working quite independently on a thought or an idea, not necessarily connected to other people who understood what they were talking about, believed what they were talking about, or saw any value in it. And I think when we put that in the patient perspective, we see that, I think a lot of these online groups and a lot of this awareness really helps eliminate that solitary feeling that I think is natural to feel when you hear the word cancer. In my mind, I don't know if this is in everyone's mind, but in my mind it actually sounds really solitary and alone, and it has a really gray and black appearance in my mind. And I think that when you think about how much these support groups can do for patients when they're not in the presence of their physician, who might be the only person that really understands what's happening in their body, more than they themselves might or their families might, that can be really impactful, and that can help make the journey maybe more enjoyable or joyful for them if they can see that there's friendship and there's bonding in that. Well, it can at least take some of the edge off. That being said, there's a flip side, right? And I think that what I've seen in the limited patient experiences that I've had so far is that oftentimes what can be challenging is navigating that patient internet experience with the patient and helping patients really understand what they read and ensuring that you do maintain those open lines of communication so that you can actually help interpret it. I know a friend of mine a while ago was saying, people won't take law advice from the internet. They'll see a lawyer when they need a lawyer, but they'll take medical advice from the internet. And that's something to be said for the amount of information that's available. And I think that while it can really help the relationship between doctor and patient to acknowledge the presence of internet and social media and support groups, you also need to maintain that level of openness and communication to help actually translate some of that knowledge, which will actually help, I think, your patient more.
And I think that's a good point. And I think like this book mentions a specific mentor that he had who talked about the risk of recurrence and the risk of complications, and who said, "But we'll deal with that when it happens." And I feel like sometimes we don't like to use words, and we don't like to bring up possible diagnoses that we think will upset the patient. But very often it's not bringing them up, but how we bring them up that does it. And kids are a great example with this. I mean, you can tell a kid something, and because they don't have a preconceived notion of what it will mean, they just take it in. And it's the parents who are filled with horror. And I think with a lot of patients, how you talk about things can be more important than what you actually talk about, and bringing that bedside can be really helpful. And overcoming some of the medical illiteracy. And even though we keep talking about cancer like it's this deep, dark, terrible hole, the reality is, you know, a lot of people, some of us, will have cancer. And they would survey hospice nurses and cancer nurses, and they would still rather die of cancer than most other things. Having had personal family experiences. Also, a diagnosis of cancer is a diagnosis that allows the family to come together, to talk about things, to think about goals of care. And so I think that the support groups and also the greater awareness among families really help with that. But it's not just, we say cancer and then, you know, it's terrible, but there is some positive things to it in comparison to other diagnoses. And I also think that partially what we're seeing is also just very much a Western gung-ho, okay, this is the diagnosis, I want to be screened for everything, I want to be treated for everything, and I want to do this. But in a lot of societies that have a different approach towards death and dying, a diagnosis of cancer is this is end of life, or this is something later on. I want to be treated, but I'm also glad that I have the opportunity to know what's coming. I don't know if that makes any sense. But,
Yeah,
it
I
makes
think
sense. And I think, oh, sorry.
I was just going to say, I think it really does, in that a lot of our patients come to us because they have a fear, and certainly in, I think, Western society, the fear is that people will die of whichever disease it happens to be that they're confronted with, and usually they seek the medical care that we provide as a means of trying to prevent that death. But certainly other cultures have either greater awareness or greater familiarity with death, and therefore they may not have the fear. And so our role as a clinician or a physician may be different in those contexts when people aren't fearful, and so it's not, protection from that diagnosis or misinformation. Like, I think it really does depend on why the patient comes in. So one thing I've learned that someone told me to ask is ask what it is that they're fearful of, or ask what it is that they were, wanting out of the visit. Because sometimes you think patients are here to find out if they have X, and they tell you no, they actually were wondering if they had Y, and the only thing that they actually want to know is just that they don't have Y, but you've been explaining to them why it's not X. And so I think kind of putting your cards on the table kind of up front, your own end, having the patient do the same, can be really helpful, because then kind of it opens those lines of communication.
Yeah, so often it's my cousin was just diagnosed with cancer, and so now I'm coming in. And yeah, you absolutely get it what their fears are. And so often it's, I'm not afraid I have cancer, I'm afraid of pain. And I'm afraid of pain and nausea. And once you say, this is specifically in cancer patients, we can treat your pain and we can treat your nausea, that can be burden relieving. And I have to say that some of the best relationships I've ever seen with patients have been with oncologists and their patients, because they have the ability to provide that relief and they have that longevity of relationship with their patients.
Absolutely.
I agree. And I think that a lot of this question speaks to this growing movement of involving patients more in medical education. A lot of the work of what Medicine X at Stanford is doing is based around this concept that the patient, the provider, the nurses, the techs, it's all part of the same ecosystem without a hierarchy, and that information is great. And I think that us as medical people, junior trainings, senior trainers, practicing doctors, we need to know what's out there on the internet, because that's what our patients are going to, and how can we help them navigate it, like you say, Leah, if we don't even know what's out there. And one question that I want to bring up that wasn't one of the book club questions but got me thinking is the role that this book has in the history of medicine. And I bring this up because the very first book that we launched the book club with was The Immortal Life of Henrietta Lacks, which was the story of Henrietta Lacks. Yeah, it was a great book. about a woman whose HeLa cells, as they were known from her cervical cancer, launched so many countless scientific findings. Probably a lot of the cancer findings were based off of her cells. And so how much better would it be to learn medicine if it came from the form of a story? How much more can you learn or retain of cancer by reading this as opposed to Robin's pathology? Or how much more can you learn about the ethics of medicine by learning these stories? Just a thought that I was having as we were
Can I
talking.
speak to that first?
Yeah.
So I would say this is my preferred means of learning. That's why I'm such a huge fan of this book. I was explaining kind of before we went on live that history has been my first love and medicine is really my second. And so for me, when I'm able to kind of find out the story of how we came to know what we know, that really adds a context and it makes it something that's kind of indelible in my memory, and so I can kind of retain that. But if I'm reading it as a series of facts and genetic mutations, it doesn't tend to stick in the same way that when you know that that acronym is actually standing for, you know, the 3 researchers who put their blood, sweat, and tears into this project or stumbled across it because of a, you know, accident in the lab. Those things are the things that I think kind of add that richness that allow it to really become a kind of sticky concept so that you remember it. And so for me, I like these stories. A lot of people, a lot of my colleagues, for that matter, when I know we were studying for exams, found some of these anecdotal or kind of sidetracked stories not of any great significance or value, but for me, that's what it would allow me to remember it.
That's true. And I think that's why even in the lack of having a real story, I think that's where a lot of these acronyms that people have to learn facts, they come from. Without having a real story, they make up their own story just so they can learn the facts.
Yeah, and I think that what's important in what Paul and you said was the fact that I think you have to, in a lot of ways, honor the people that have come before you. And when you hear about the stories of the people that really did put their blood, sweat, and tears into the discovery of our rods or HeLa cells, and you actually understand what they went through, I feel like there's honor in that, and there's acknowledging what they did in the steps before you. And that's probably one of my favorite parts of this book, is you feel like you really understand what brought us to this point, and you can acknowledge and be grateful for that. And I think that's really what medicine, I think, can be at its best, when you actually see and acknowledge the work of the people around you, as we all do in our teams, but the people who came before you and established even our field of emergency medicine before we became emerge docs and emerge residents. So I really enjoyed that about the book, and I'm glad you brought it up.
Yeah, yeah.
I think it's tricky, though. It's a double-edged sword, though, because this book really is about how the sausage is made. Like, it's 50 chapters of failures, of unnecessarily large surgeries or unnecessarily small surgeries or unnecessarily damaging therapies that didn't change survival. I mean, it's the stories of the petty rivalries between researchers and egotistical sort of movements and funding battles from Congress. And it's a fantastic book to read, and it covers some great stories in history. And really, I agree with you, integrates the idea of screening sensitivities and specificities and you wouldn't want to screen and all the complications. I think if I was somebody who had a new diagnosis of cancer, this is not a book I would wish to read.
Yeah,
because on some level, on some level, I think that the somewhat false idea that the state of medicine is the best it's ever been and is perfect in a way, it allows people to sleep a little better sometimes. And I think it's great. I think it's important to know about the history of medicine, because that teaches you that most of what we think is true today won't be true tomorrow, and that there's development of everything from therapies to screening. And meeting the people that have developed these techniques is really great. I loved the book. But I think it's a double-edged sword, just because it shows you how the sausage is made, and I don't know you want one after that.
And I think, but that speaks to who this book maybe was designed to be written for, and who actually reads it. And I'd be curious to know actually who ends up reading this book, like who picks up this book off the shelf, because we're all medical professionals. we're all on the in the know and have a huge background in science, and a lot of this book probably makes sense because of our background. But I want to just point out, I appreciate your healthy skepticism, and I'm going to raise it one more level. And I appreciate that you say that this book is all about mistakes and about petty arguments, but that's a very retrospective look on what the advances are. And I think that it is worth acknowledging the fact that at the time, those arguments maybe weren't petty at all, and those mistakes, as much as they were mistakes, and maybe they took out too much or they didn't take out enough, but without that, I don't think that the ideas maybe would have been there. And I think that we can look back on history and see it through a retrospective lens, and that's important. But also looking at the mistakes that we make today, just as relevant, I think, to make errors in, I think, personally, in the exploration of finding something that's new and better. And you need to make mistakes to do that. So
I have 2 points to make of that. One is that Jordana and I were actually talking about this yesterday, and I was talking to her that while I like the book, it's so dense, and I wonder, clearly it won the Pulitzer, and that means that more people besides doctors had to have read this if it won the Pulitzer.
It was on the New York Times best-selling list as well.
Right.
And it's wonderfully written. It's wonderfully written.
And I get lost in some of the details myself, and I am a doctor, and I'm just wondering, how can the layperson really digest it? But clearly, a lot of them are. And then the other point I wanted to make was that what I do like about books like these, and the books, Immortal Life of Henrietta Lacks, is that it serves as a very, very, very strong reminder of the ethics of medicine. The way they conducted clinical trials were atrocious by today's standards. And exposing kids to 4 combination of chemotherapy, 5, 6, 7, whatever it may be, in the hopes of maybe adding on 1 more day of life without, I'm sure informed consent was not there. I'm sure the parents were not notified as to everything that was going on. And so when you learn, especially, how these doctors whose names appear on diseases, and you learn about their backstory, and you learn a lot of their ethics perhaps don't match up to today's standards. That's why I think we read books like this.
I think it was certainly a fascinating read. It's funny, there's a Canadian researcher and physician. Her name was Dr. Vera Peters. I don't know if you guys are familiar with her story, but it is mentioned very briefly in the early part of the book. She's the one who pioneered the use of radiation to treat Hodgkin's lymphoma. And so it's funny because she's got this great quote that research isn't really a question of time, but it's a matter of curiosity. And so I think that the book speaks to all of our curiosity with this, disease we call cancer. And I think the reason that it's such a large book is because there are so many people over so many years who have been so curious. He starts the, story with a story of a Persian queen, and brings it right through to the modern day. And so I think because it's touched so many lives and so many researchers and so many clinicians and so many different people who have been so curious, I think that's why this book has been so popular, both to medical people and non-medical people alike.
I think that's very valid, and I think that's one of the reasons why this book meant so much to me, is I think it does impact everyone who it touches. And I think that maybe people might not understand all the science and they might not understand the words, but they understand the stories. And going back to what we talked about earlier, I think the stories are what really help people understand the journey. And you might not understand what an R-rod is, but you'll understand the struggles to actually discover it and what it meant. And he captures that, I think, very eloquently and quite simplistically for people. He really shows you the moments, and you're there. I felt like I was right beside the people in those moments of, great triumph or impossible, insurmountable challenges. And that's I think what made this book so widely read, and I think widely accepted as a story.
So I think we need to end this. This was a great discussion. Maybe we can just go around starting from Matt, Paul, and then ending with ALiEM. You have 1 sentence to summarize your thoughts or any last-minute comments you want to make. Start with
I thought it was a great read. It was a good reminder that we sort of stand on the shoulders of giants, and that there's a lot of history behind everything we do.
Paul, what do you think?
Oh, I love this book. I would say it does a great job of, I think as Matt was saying, pulling back the curtain and showing really the complexity that is modern medicine and the imperfection of it as well.
Aaliyah?
And I think I'm going to quote Matt from earlier on today when he said, "What we do changes us." And I think that there's no greater truth in this book and in life than that.
And I think one of the things that I take away the most of this book is a reminder of how far we've come and how far we have to go in medicine and as being doctors. So that's pretty much the end of February's book club. In March, we are doing Being Mortal by Atul Gawande, and I hope to see you then. Bye-bye.